Majority of core biopsy results I sign every week are not breast cancer. They're benign. Yet every single patient who reads one tells me exactly the same thing. It might as well be written in Russian. And I get it. If you're staring at a page riddled with phrases like tubule formation, nuclear pleomorphism, mitotic rate, your heart is beating frantically. But please stop the panic. Seriously, just hit the pause. Because by the end of next 10 minutes, I promise you, you will know exactly what those numbers and those words mean, what they do, and absolutely do not say about your treatment options. And most importantly, the 3 crucial questions you need to ask at your next appointment, so you leave feeling informed and empowered instead of completely overwhelmed. We're going to demystify this together. So let's start. The report you're holding is just the first chapter, and we call this core biopsy report. Now, there is a crucial distinction right off the bat. This report is not the same as much larger, more comprehensive report that will come later when you have your surgery. Think of it as a movie trailer. It is designed to give you the highlights, a sneak peek, but definitely not the full plot, every character, or all the surprising twists. A good trailer can tell us if the film is going to be an action-packed blockbuster, a tear-jerking drama, or a light-headed rom-com. In our medical analogy, that translates you're dealing with DCIS, invasive cancer, or something entirely benign. But what trailer cannot tell you is reveal every single plot, every single character backstory, and that distinction matters. Why? Because I meet patients all the time who are in complete panic because nothing about lymph nodes is mentioned. They worry crucial information is missing. If the lymph nodes look normal on ultrasound, they will not be biopsied at this stage. This will be done at the time of surgery. This initial core biopsy report is designed to answer 4 fundamental yet incredibly important questions. First, is there cancer present at all? Second, if it is cancer, what flavor or type is it? Is it ductal, lobular? Is it something else entirely? Third, how angry does it look under the microscope? That's what we refer to as the grade. And finally, does it have the key receptors that act like little molecular doors, either opening up or locking down specific treatment pathways? Everything else, details about the full extent of the tumor, whether it has spread to lymph nodes, or if it's gone beyond the breast, that all waits for the surgical specimen. So take a deep cleansing breath. You're not missing data because your pathologist forgot something important. That data literally cannot be collected or assessed yet from a needle biopsy. It's simply not there. This report is your initial roadmap, guiding the very first steps, not the entire journey. Pathologists are so meticulous and they love categories. It helps them organize the microscopic world. So your report will inevitably land squarely in one of 3 main buckets: benign, atypical, or malignant, which is just a fancy word for cancer, whether it's invasive or non-invasive. In this video, we will concentrate on malignant or cancerous diagnosis. So the cancer bucket list includes the wording of ductal carcinoma in situ, or DCIS, which is non-invasive cancer confined to the milk ducts, or invasive ductal carcinoma, which is the most common type of invasive breast cancer, or lobular carcinoma, or any other more rare subtypes like medullary, mucinous, tubular, metaplastic. Each of these names actually tell us 2 very important pieces of information. First, the cell of origin, where the cancer started, like is it a ductal or a lobule? And secondly, whether it has broken out of its original confines and became invasive. This is critical for guiding treatment. My advice is write down exact phrase down, because you will repeat it to every single doctor, nurse, and specialist you meet on this journey. So you might as well practice pronouncing it now, because the words we use are so complicated. So get comfortable with it. It is part of your story, and understanding it is the first step towards taking control. Grade is not a stage. Let's take on one of the biggest sources of confusion, because I see it every time I have to give a patient a cancer diagnosis. In a nervous, adrenaline-fueled brain, they're just being told cancer, grade and stage sound practically identical. They roll off the tongue similarly, and both relate to how bad the cancer is, right? Actually, that's wrong. Mixing them is like confusing your IQ score with your mark in the school. They both matter, yes, but they measure entirely different things and give you different perspective on your academic standing. So we need to kill that confusion once and for all. So let's break it down. Grade answers the question, how ugly do the cancer cells look under the microscope? It is only about the microscopic appearance and behavior of the individual cancer cells themselves. Are they well organized and behaving somewhat politely, or are they chaotic, disorganized, and aggressively dividing? This gives us a sense of tumor's inherent biological aggressiveness. Now, stage, on the other hand, answers a completely different question. How far has the army of cancer marched? It's the extent of cancer spread within the body. Has it stayed put in a breast? Has it moved to nearby lymph nodes? Has it traveled to distant organs? Now, the kicker on this initial core biopsy, we can only give you a grade. Why? Because we haven't yet had the opportunity to assess the lymph node involvement pathologically or any potential body-wide spread. Those assessments require further imaging and often surgery as well. So grade is typically decided by something called Nottingham pathologic grading system, which looks at 3 specific features of the cancer cells. 1, tubule formation. How much do the cancer cells still try to form normal duct-like structures? If they form lots of tubules, it's a good sign, you get score 1. If they form very few or none, it's a worse sign and you get score of 3. Number 2, nuclear pleomorphism. This refers to how abnormal the nuclei of the cells look like. Nuclei are the control centers of the cell. Are the nuclei all uniform and small? You get a score of 1. Or are they big, irregular, and varied in shape? You get score of 3. The more abnormal, the higher the score. And then number 3 in the Nottingham grading system is mitotic count or mitotic rate. This is literally a count of how many cells are effectively dividing and multiplying in a given area. A low mitotic rate means slow growth, and you get a lower score of 1, and a high means rapid growth, score of 3. So now each of these scoring systems of tubules, nuclear pleomorphism, and mitosis gets you a score of 1 to 3, and then you add them all up. And your report will show this. So if you have a score 3 to 5, that gives you a grade 1 tumor. These are generally considered well-behaved, more differentiated, and usually slower growing. They tend to look more like normal breast cell. Now, your score might be 6 or 7, and this puts you in grade 2 category. These are intermediate or middle of the road tumors with some features of both low and high grade. And then you might get a score of 8 to 9, and this is a grade 3 tumor. These are the rowdy ones, poorly differentiated, looking very abnormal and typically faster dividing, and they're more aggressive. The grade number is incredibly helpful. It helps us decide whether chemotherapy is likely to be a beneficial part of your treatment plan. But there is a key point. It never stands alone. We marry that grade information to your receptor data and later to your stage information after surgery. So while grade of the cancer is vital, it is just one piece of much larger, intricate puzzle. So don't just focus on this one thing. So in your report, you're also going to get the findings of your receptors, which are the keys that unlock or lock treatment doors. So this is the next part of your diagnosis report. And often your eyes jump straight to that area or immunohistochemistry section of your report. Here you're going to find 3 acronyms: ER, PR, and HER. ER stands for estrogen receptor, and PR stands for progesterone receptor. These are the proteins on the surface of the cancer cells, or sometimes inside them, that can receive signals from the estrogen and progesterone telling cancer cells to behave in a certain way. Your report might say something more than 90% strong nuclear positivity for ER, which means it's a ER positive cancer cells and they are responding to estrogen. This is actually a good news because it means that we can attack the cancer afterwards by blocking the estrogen with 2 different tablets that we have, either aromatase inhibitors or tamoxifen. These hormone-blocking pills can be incredibly powerful in preventing recurrences for ER-positive cancers. I will put a link below to my previous video about tamoxifen. Conversely, if your estrogen and progesterone receptors are negative, it means that your cancers don't have these receptors or they have very few, and therefore the cancer cells doesn't need estrogen or progesterone, and taking hormone blocking pills won't help. It would be like trying to unlock a door with the wrong key. It just won't work. PR works in very similar fashion to ER, but it's progesterone. Often the cancers are ER positive and also PR positive, but they don't have to be always the same. You could have ER positive, PR negative cancer, or ER negative and PR positive cancers. They both contribute to the overall picture of your cancer's hormone sensitivity. Now, the third marker is HER2, and this is growth accelerator. It's called HER2, and it stands for Human Epidermal Growth Factor Receptor 2. In some countries, it's also called ERB-B2. And this is a completely different beast. It's another protein, but this one sits on the cells and acts like a powerful gas pedal for cell growth. Or the results can show that immunohistochemistry, or IHC, for HER2 comes back as 3+. That means positive. 1+ means negative, or 2+ means in between, and a follow-up test called FISH, and it's spelled FISH, which means fluorescence in situ hybridization is done. And this can mean that a test is either positive or negative. If the cancer is positive, it is like this car has extra gas pedal constantly telling it to move fast or to grow rapidly. And these are aggressive forms of breast cancer. But there is incredibly good news. We have now an arsenal of targeted HER2 drugs to basically stop the growth of these cancer cells. If you want to know more about this, there's a link in the description below to one of my videos that talks about the HER2 positive breast cancers. Finally, you might hear the term triple negative breast cancer. This simply means that ER, PR, and HER2 are all negative. In other words, the cancer doesn't have any of these three major keys that we can target with hormone therapy or HER2 targeted drugs. For triple negative breast cancer, chemotherapy is usually combined with the surgery for treatment of these breast cancers. So once you've had the diagnosis of ER, PR, and HER2 status, the beauty is that these receptor results rarely change between your initial biopsy and subsequent surgery. This means that your core biopsy report gives you remarkably reliable roadmap right from the start, allowing us as doctors to begin planning your personalized treatment strategy almost immediately. There is another marker called Ki-67, and some reports include this and some don't. In Wellington, we report it sometimes, but most of the times we don't. If it's not reported, don't panic. But if you do, you'll spot something like Ki-67 on 25%. The number tells us the percentage of cancer cells that are actively in the division cycle or they're trying to multiply. Think of this as your speedometer of your tumor. A lower percentage generally indicates a calmer, slower growing tumor, like 5 to 10, while higher percentages, 25 and above, suggest more aggressive, faster dividing cancers. Medical oncologists or chemo doctors sometimes use this information to guide whether chemotherapy may be beneficial in addition to hormone pills. It might sometimes change the treatment decision. But you need to understand that a Ki-67 is not a definitive answer by itself. It's not a standalone predictor of outcome. Instead, think of it as another valuable data point that gets thrown into the same backpack with your grade and your receptor status. It's a part of overall picture, providing context rather than being placed on a pedestal alone. It helps us refine our understanding of the tumor growth. Let's talk about two very important concepts that you have heard mentioned in the context of breast cancer, which you will almost certainly not find in your biopsy report, and that's margins and lymph nodes. And there is a very good reason for their absence. Margins is a term that refers to the edge of the tissue that surgeon removes during the operation. So if I remove a lump cancer was like that, and there is surrounding normal breast tissue, the pathologist will measure the distance between the cancer and the other edge of that normal breast tissue and tell us how wide the margins are. And we want to have clear margins of healthy tissue around the cancer, because you need to have a surgery to find the edge. This will never be in your core biopsy report because the lump has not been removed. Core biopsy is fundamentally different. It's just a skinny needle that takes out tiny cylinders of tissue. It's a diagnostic tool, not a therapeutic removal like a surgery. So you cannot assess margin for a few flecks of tissue retrieved by this needle. So if there is no margins in your core biopsy report, this is not oversight. It is because it's physically impossible to assess margins at this stage. The lymph nodes are tiny organs that are part of your immune system. And in breast cancer, they're crucial because they're often the first place that the breast cancer cells spread outside the breast tissue. Knowing if cancer has reached the lymph nodes, it's a major factor of determining the stage of the cancer and guiding treatment decisions. If you've had an ultrasound and this has shown that your lymph nodes is enlarged, you might have had a biopsy of that lymph node to see if there is any cancer in it. But if the lymph nodes looked negative, then you wouldn't have a biopsy. So in that case, the lymph node status cannot be judged from tiny pieces of only a breast tissue that was obtained in core biopsy. We do not biopsy routinely normal-looking lymph nodes. We will do that at the time of your operation, and that's called sentinel node biopsy, and I will do another video about that in future. So if someone tells you that my biopsy said 0 out of 3 nodes, this means that result has been gained after the surgery, after 3 sentinel nodes were removed, and none of them had cancer in it. This was not done by core biopsy. It is incredibly important to keep these stories straight and understand the limitations of each report. Don't torture yourself with missing facts that were never ever supposed to be in your initial core biopsy report. It's not a diagnostic flaw. It's simply how these samples are taken and what information they're designed to provide at each specific step of diagnostic process. You will get lymph node information, but will come later when you have had surgery. What happens if the biopsy result differs from surgery? This is the question that often causes quite a lot of anxiety. What if the biopsy was wrong? The diagnosis of the cancer, invasive or ductal carcinoma in situ, is not wrong. This is because these days we're deciding this on core biopsy, not on FNA. We cannot give a lot of this information on the FNA, and hence we don't do or recommend using FNA. What might change between your initial core biopsy report and a later in surgery specimen is that sometimes in about 15% of the time, the grade of cancer might change. What that means? It means that the needle happened to sample the part of the cancer and not all of the cancer. And when we remove the whole cancer, we find exact composition of cells everywhere. It's not a mistake, it's just the nature of sampling. It's like if you take a bite in a blueberry muffin, and one bite might have just one blueberry and a lot of dough, and then the other bite might have 5 or 6 blueberries. It's exactly the same when it comes to core biopsy. Occasionally, very rarely, receptor status can flip or change. And we're talking about very rare situation. If the cancer all of a sudden looks quite different to the one that was on a core biopsy, they might look to repeat the EIPR status. But most of the time, we don't repeat it. And HER2 status rarely changes. Why does this happen? Tumors are not uniform. They're a mix of different cells, and in different parts of the same tumors, you can have slightly different cells. So if your surgery changes your original tumor grade and it ends up being higher grade or has a different receptor characteristic than we initially thought, we simply just pivot or change the plan. And the plan is kind of like GPS. You could take a different road and get to the same destination in a different way. So if you miss a turn or hit unexpected detour, the GPS doesn't just give up. It reroutes, finds the best new path. And we do the same. We adjust the medication. We consider different surgical approaches or modify radiation plans. The goal still remains the same, is to give you the most effective treatment for your specific cancer. We want to nuke that sucker. 3 questions to ask at your next appointment. Now that you're armed with this newfound knowledge, you're ready to walk into your next appointment feeling much more confident. But don't just sit there and nod. To truly solidify your understanding and ensure you get the clarity you deserve, you must ask these 3 critical questions. And trust me, your medical team will appreciate your engagement. Number 1, walk me through each line of this report in English, not Latin. This isn't about being confrontational. It's about clarity. Medical professionals are often so accustomed to jargon that we forget that it's foreign language to patient. Insist on a plain language explanation of every number and every percentage. Understanding each piece of this information helps you build the full picture. Number 2, based on what we know today, what are my treatment buckets? Surgery, radiation, chemotherapy, endocrine or hormone blockers, or all of the above? This question shifts the focus from diagnosis to action, and it forces us to outline the broad categories of treatment that are likely on the table for you given your specific results. Are you looking at surgery first? Will radiation almost certainly be part of the plan? Does the cancer need chemotherapy? And should we give chemotherapy before or after treatment? And number 3, under what circumstances would the plan change? And this question shows you're thinking ahead and anticipating potential shifts. Sometimes it's different treatment plans. If you have a mastectomy, you may or may not require radiation, but if you have breast conserving surgery, you're likely, or you almost always have a radiation for invasive cancer. And here is a pro tip. Write the answers down. Seriously, bring a notebook or use your phone's notes app. Some people even record the appointments. And this is because memory under adrenaline and stress is notoriously terrible. Also bring someone with you because they remember different part of the story and they have different questions to ask. You think you'll remember everything, but trust me, you won't. As soon as you hear the C word as diagnosis, everything just gets out of your head. So having it written down allows you to review it later, share it accurately, and feel more grounded in the information. Okay, let's be real for a moment. The period between getting your biopsy result and formulating a definitive treatment plan is often one of the most agonizing parts of this journey. This is a phenomenon we call scanxiety, but it extends to waiting for any medical results or next steps. It's real, it's intense, and it can be utterly paralyzing. Different countries are different in what and how quickly next steps happen. In New Zealand, it depends on a public and private system. In the private system, there is usually a little bit less wait time than in a public system. Also, don't try to be a superhero at work. Tell your employer you need half days or flexible hours for medical visits and treatments. Prioritize your health and well-being. Remember, your mental health is just as important as your physical health during this time. If this information has helped cut through even a sliver of your confusion and fear, please hit that share button. And if you want a concise, one-page cheat sheet that lists every single item we talked about today, explained in plain language, just drop the word biopsy in the comments below. My team will email it to you for free, no strings attached. Cost of the treatment. Among all the medical jargon, there is a silent stress that often goes unaddressed, and that's the financial burden. We're lucky in New Zealand's public system that treatment on its own, it's not associated with any financial cost. There are mental burdens associated with longer waiting times. In New Zealand private system, there may be associated costs, so please discuss these with your insurance provider. Most surgeons and oncologists are affiliated with all insurances. There's also cost associated with taking time off work for some people for all the appointments as well as treatments. Okay, we've covered a lot of ground. Let's distill it down to the absolute essentials, the core truths that you can carry with you. This is your 30-second recap, something you can literally tape to your mirror to keep these key concepts on top of your mind. Grade is a microscopic anger score. It's 1 to 3. It tells us how aggressive the cancer looks and acts. Stage is a travel score. It's unknown until the surgery. It tells us how far the cancer has spread, and your biopsy doesn't tell us this yet. ER, PR, and HER2 are treatment keys. These receptors dictate which targeted therapies will work or won't work. Margins and nodes are not included in this report. They cannot be assessed from needle biopsy unless your lymph node has been enlarged on ultrasound. Ask, write, share, and breathe. Be your own advocate. Engage with your medical team. I know that the results paper in your hand, even after all this explanation, is still charged with fear and uncertainty. But remember, you now speak the language. You can confidently separate grade from stage. You understand the receptors are the traffic lights guiding your treatment, and your grasp with the absence of lymph node data isn't a mistake, but simply the biology of how these samples are taken. Print the script. Circle the sections that resonate most with your report. Mark it up, and then walk into your next appointment not as a passive recipient of information, but as a most informed, most prepared patient in the room. You are an active participant in your care. And remember, even if the news is indeed cancer, we have more tools today than at any other time in history. We have targeted therapies, immunotherapies, and advanced surgical techniques that are turning once lethal diagnosis into chronic, manageable condition for so many. Your crucial role is to keep showing up, keep asking questions, and keep advocating fiercely for your own body and your peace of mind. My job and the job of your entire medical team is to keep translating the complex into comprehensible until that initial wave of fear melts into a clear, actionable plan. If you found value here, please subscribe and share this with someone who's still doom scrolling at midnight. Together, we'll replace confusion with clarity, one empowered patient at a time. In my next video, I will explain more about staging of the breast cancer. Bye for now.